Okay, so today we're going to address a very common topic of chronic hypertension in the context of how it affects pregnancy. Um, and I just put together a quick sort of case presentation of something that I'm sure we all see very, very frequently, especially in the realm of maternal fetal medicine. But just to start us off with a vignette, we have a patient who comes to the OBGYN office for an IUD removal. She's 35 years old, has a history of chronic hypertension that was diagnosed about 9 years ago, and she and her husband want to have a second child. Her first pregnancy was complicated by preeclampsia with severe features for which she was delivered at 29 weeks, along with growth restriction. Her past medical history is significant for chronic hypertension, as we mentioned, class 3 obesity and polycystic kidney disease. And for her chronic hypertension, she is being controlled on 2 medications. This would be a very typical patient we would see for a visit in her OB/GYN office or even in the maternal fetal medicine office. So chronic hypertension, as we all know, is very highly prevalent on the global scale. Essential hypertension is the most likely cause of hypertension in individuals. It is on the rise. And risk factors for people to develop hypertension include advanced age, obesity, strong family history. Race definitely plays a role in it. Um, um, Lifestyle, such as high sodium diets or excessive alcohol consumption, inactivity, which we see a lot, and poor social circumstances all play a role in somebody's risk for developing hypertension throughout the course of their life. Hypertension can also be caused secondary to another pre-existing condition, such as renovascular diseases, endocrine diseases, tumors, drug use, both illicit drug use as well as long-term prescription and non-prescription drug uses. And obstructive sleep apnea is also a risk factor for individuals to develop hypertension over the course of their life. With regards to pregnancy, the prevalence of chronic hypertension in pregnancy is estimated to be anywhere as high as 3%. I've actually seen estimates as high as 3 to 5%, but it's increasing. And it's increasing over time due to a number of potential factors, many of which are the risk factors we just talked about for developing hypertension in general. But especially in the Southeast, we have an increasing prevalence of obesity and delayed childbearing. A lot of our patients are advanced maternal age or starting their childbearing in later years due to deferment for careers, education, etc. So these are all risk factors for the increasing prevalence of chronic hypertension we are seeing in the pregnant population. Chronic hypertension in the pregnant person is defined as either hypertension identified prior to pregnancy or prior to 20 weeks of gestation. And traditionally, it was diagnosed with a systolic blood pressure of greater than 140 and or a diastolic blood pressure of greater than 90. And ideally, you'd have two measurements that are abnormal, at least 4 hours apart, unless faced with severe range hypertension, in which case that time frame for diagnosis could be shorter than 4 hours. A number of years ago, in 2017, the American Heart Association and the American College of Cardiology changed the criteria of classification for hypertensive in the non-pregnant adult, which is not in line completely now with what we have traditionally thought of by the American College of OB/GYN. So category 1, which would be considered normal, is a systolic blood pressure of less than 120 and a diastolic blood pressure of less than 80. Traditionally, we would say normal blood pressure for an individual is 120 over 80, but apparently now is less than that. Category 2, which is considered mildly elevated or elevated blood pressure, would be a systolic of between 120 and 129, and a diastolic blood pressure still less than 80. Their category 3, which is classified as stage 1 hypertension, is now a systolic blood pressure of 130 to 139 or a diastolic of 80 to 89. And stage 2 hypertension is a blood pressure of 140 or greater and or a diastolic of 90 or greater. Of note, to make a diagnosis of stage or category, it's basically the higher of the values. So if there's a disparity between systolic and diastolic blood pressure, the higher value wins to determine the category of hypertension. Nowadays, and again, we're talking still talking about the non-pregnant population, recommendations to initiate therapy for someone with a diagnosis is as early as category 3 or stage 1 hypertension with one or more additional finding and or risk factor, which could be known cardiac disease, kidney disease, age, and or pre-existing diabetes. I think there's a trend towards movement of treating stage 1 hypertension and even in younger individuals without significant risk factors. So with the change, especially with this change in definitions of hypertension, sometimes establishing a diagnosis of chronic hypertension in your pregnant individual may not be straightforward. Many otherwise young, healthy individuals may not seek routine care, and therefore a log or a history of blood pressure may not be known. And in fact, the first time a person may seek medical care in a young, otherwise healthy individual may be during her first prenatal visit. The physiology of pregnancy can often, especially in the first and second trimester, can often mask some previously undiagnosed hypertension. Because recall, the physiology of pregnancy, which starts very early after conception, changes the maternal cardiovascular system fairly substantially. There's both a decrease in systolic and diastolic blood pressure, which begins early in pregnancy. The diastolic blood pressure may decrease more than the systolic blood pressure, maybe about up to 20 millimeters of mercury. This is due to a significant decrease in systemic vascular resistance that can, again, I'll call it, occurs within the early first to mid first trimester. Normally, a pregnant person will see their blood pressures drop to their lowest point between about 16 and 22 weeks. And then towards the end of the pregnancy, their blood pressures rise such that by the end of a pregnancy, their blood pressures are at a point about equal to where they are in the non-pregnant state. For people who have chronic hypertension, they may not see the same significant decrease in blood pressure in the early parts of pregnancy, but they do typically see a rise toward the end of pregnancy. But it's clear that for somebody who is undiagnosed going into pregnancy, a normal pregnancy physiology may mask that diagnosis of chronic hypertension. As blood pressures return to, quote, the normal state or the normal pre-pregnancy state in the third trimester, when we see individuals who have an undiagnosed chronic hypertension, but we see their blood pressures rise towards the end of pregnancy, they may be labeled as gestational hypertension or even preeclampsia. A number of people who have a history of chronic hypertension will have a baseline proteinuria of over 300 milligrams per 24 hours. And thus, when we see them with their first exacerbations of blood pressure later in pregnancy, they may already have this proteinuria and may be incorrectly diagnosed with preeclampsia when this is in fact just an exacerbation of their gestational hypertension. Oftentimes, this distinction between preeclampsia and chronic hypertension or exacerbation may not be evident until pregnancy is over and you're looking retrospectively and figuring out that, in fact, this was indeed chronic hypertension, not a new onset preeclampsia. That being said, a large portion of pregnant women who do have a history of chronic hypertension will develop superimposed preeclampsia at some point in time as pregnancy goes on in the second or third trimester. So this next slide is just taken from the ACOG practice bulletin on hypertension and pregnancy. Just shows what are the current definitions that ACOG still uses, which is hypertension and pregnancy being greater than 140 over 90, severe range being greater than 160 over 110, chronic hypertension, as we previously mentioned, either diagnosed prior to 20 weeks or prior to pregnancy, and then superimposed preeclampsia is a history of hypertension before pregnancy or before 20 weeks with exacerbations of hypertension values. You're supposed to go the other way. There we go. And the reasons we care about chronic hypertension in pregnancy is because of both risk to mom and to baby. In worst cases, there's risk of stroke or death to mother. There's risk of cardiopulmonary complications, obviously preeclampsia, placental abruption, higher risk of needing cesarean delivery, hemorrhage, complications for the baby, being growth restricted, which we commonly see, stillbirth or perinatal death, extreme preterm delivery, and a higher risk of congenital anomalies. So when somebody comes in and has a diagnosis of baseline chronic hypertension and they are now pregnant, a certain workup is recommended, including a baseline lab evaluation to assess not only complete blood count, but metabolic profile, BUN creatinine, LFTs, and doing an assessment for proteinuria, because as we said, people with chronic hypertension can sometimes be spilling at baseline more than 300 milligrams, which is a cutoff for diagnosis of preeclampsia. 24-hour urine collection is still the baseline, or still the gold standard for establishment of proteinuria, but a spot protein to creatinine ratio is less than 0.15 safely indicates a 24-hour urine of less than 300 milligrams and should be sufficient for baseline screening. For people who have had chronic hypertension long-standing or who have been poorly controlled for 4 or more years, they're more likely to have cardiovascular changes, such as hypertrophic changes or risk for ischemic heart disease. So a baseline, either electrocardiogram or echocardiogram with women with long-standing or poorly controlled disease is recommended. And I will say that we've been having discussions in our group recently about lowering the threshold of people who we do want an echocardiogram during pregnancy, because in our region of South Carolina, we are seeing a lot of people with multiple comorbidities, but having heart disease that is either pre-existing and or diagnosed during pregnancy. Review of their medication list and adjusting. This is ideally done in a preconception setting, but if they are pregnant once they hit the office, reviewing a medication list and transitioning to more pregnancy-associated safety medications, specifically discontinuing ACE inhibitors and angiotensin receptor blockers, which have known complications for babies, risks of impairing renal development, and increasing the risk of oligohydramnios, anhydramnios, and congenital anomalies associated with those, and renal failure after delivery requiring dialysis with an increased risk potentially of stillbirth and neonatal demise. So we want to transition these people to pregnancy appropriate medications. The common ones that we see that are endorsed by ACOG, and this is not necessarily an expansive list, but labetalol is one of the go-to medications, and it's safe in pregnancy. Also, calcium channel blockers such as nifedipine are commonly and widely used. Methyl-dopa is one of the older medications that are out there, essentially acting. I don't know that it's used extremely popularly nowadays. And they also mentioned the use of hydrochlorothiazide or diuretic, which is stated here as not a first-line treatment, would be a second or third-line agent. I would say not commonly a go-to agent for initial management of hypertension in pregnancy. But more on that in terms of use of diuretics in pregnancy. A lot of people who have a pre-existing diagnosis may come in on a medication such as lisinopril, hydrochlorothiazide. They may be on a diuretic at a low dose prior to pregnancy. As far as we know, there are no known associations with fetal anomalies, but theoretically, we don't typically use diuretics in pregnancy for fear of interfering with the normal volume expansion during pregnancy. Some would suggest that they would not initiate a diuretic in pregnancy as a first-line agent without an underlying indication. But if somebody were on one prior to pregnancy, it's not unreasonable to continue that. Loop diuretics such as Lasix, again, not commonly used in the antepartum setting, but may be necessary in some of our patients that we see with pre-existing comorbid cardiac disease who need reduction in their fluid status. So those can certainly be used in pregnancy if indicated. Medications to avoid, if possible, would be medications like atenolol, which is a beta-1 selective blocker, just a higher association with growth restriction and low birth weight. Also, if possible, propranolol, which is a non-selective beta blocker, which, again, theoretically, due to its blockage of beta-2 receptors, could reduce uterine quiescence and reduce myometrial relaxation, making the uterus more irritable. Now, that being said, we have safely managed patients on propranolol for other indications during pregnancy with no significant complications. The other thing when you're seeing your patients with chronic hypertension early in pregnancy is to initiate a low-dose aspirin, which preferably between about 12 and 16 weeks for reduction in preeclampsia risk. As far as discussing treatment of chronic hypertension in pregnancy, things changed about a year or so ago once the CHAP trial was introduced back in April of 2022. Previously, we didn't institute treatment antihypertensive therapy in pregnancy for somebody with maybe mild chronic hypertension early in pregnancy or pre-pregnancy who were not being treated. Therapy wasn't instituted until a woman would start having severe range or close to severe range blood pressures. But the CHAP trial was completed in 2012, published in 2022, which was a multi-center trial and basically randomized women into two groups. One group that they would treat early on in pregnancy with mild hypertension, and the second group that they was treated the usual way where therapy was not initiated until they reached or became close to severe range blood pressures. The findings of the trial showed, in summary, a reduced risk of preeclampsia in the group of patients that were treated early on, a reduction in preterm birth, specifically iatrogenic preterm birth less than 35 weeks, a reduction in placental abruption and fetal and neonatal death, and no difference in the rate of birth weights less than 10th percentile, which was a concern previously of starting therapy early. So the threshold that was used and the Society for Maternal Fetal Medicine statement basically used a threshold of 140 over 90. As the statement reads, the Society of Maternal Fetal Medicine recommends treatment with antihypertensive therapy for mild chronic hypertension in pregnancy to a goal of less than 140/90. Additionally, patients who are treated with chronic hypertension should continue established therapy during pregnancy and/or change to a regimen that is more pregnancy compatible. So that was a shift that came about in 2022. And that was a slide that I just read there. The synopsis statement from the Society of Maternal Fetal Medicine can be read here, which is their synopsis of that CHAP trial. So that's kind of the lay of the land at this point in time.